Morning.
Okay, now I think we're good. All right, we start, as we always do, by talking a little bit about where we are with respect to opioid overdoses that we've experienced here. And again, keeping in mind that even one of these deaths is too many. We do this really as a way of seeing where we are. So since our last meeting, which was April 7th, we have experienced 27 additional deaths to which we responded across the county. Obviously, 27, as we always say, the circle of 27 people is huge when you think about everybody who's impacted. The somewhat good news is that this number puts us in a place where we have seen an 18% decline here in the county from January 1st until May 12th, which is when we have our last report. We are now seeing an 18% decline over last year, which is significant and is really a testament to the work that everybody on this call is doing. This is particularly good news given where we have been during the pandemic. So it is my hope that we continue these efforts and we stay in this place. The downside of what we have seen is last year in this same time period, the January 1st to May 12th, we had experienced one suicide connected to a substance. This year, we have had 4 in that same time period. So a very significant increase. And those are circumstances where when our troopers respond, it is more than just a hunch that it might have been an intentional overdose. Those are the situations where we have a note, where we have statements from people, where it is very clear. So that number might actually be a little bit higher. We only classify as someone as having died by suicide when it is uncontroverted. That is what took place based on, notes they've left, that sort of thing. So that is very concerning, and it certainly balances that somewhat good news of the 18% decline. It's particularly sobering since May, as many of you know, is Mental Health Awareness Month. And those numbers that we're seeing of people dying by suicide really highlight why it's important to be raising the awareness, to be destigmatizing getting help, making sure people know what resources are out there, and really advocating for additional resources. I think if you saw there's an article in the Boston Globe this morning about the fact that accidents in terms of people falling or medication issues or whatever, not surprisingly increased in hospitals during the pandemic as hospitals were more short-staffed and more people in there. But what also came out at the hearing they were conducting about it was the incredible increase in the number of self-inflicted injuries, particularly among kids between 12 and 19, that the doctors saw during that same period of the pandemic. So I think it's just another very stark illustration of that. And you may have also seen, and it's really connected to the work that we began here a couple of years ago, the Surgeon General, Dr. Murthy, is really sounding an alarm about that epidemic, what he's calling an epidemic of loneliness and social isolation. He just put out a report about that. If you haven't seen that, we'll put it in the chat so people can read that. But he talks about the fact that, and I think this is really pretty stark. We all know now, if we never knew before, the impact of smoking on our physical health. And he is comparing the kind of isolation and loneliness that people are experiencing as having an impact on people's health comparable to smoking 12 cigarettes a day. So if you think about, if you smoke 12 cigarettes a day, what would that mean for the downtick, if you will, in your health? he is saying that this loneliness and isolation that we're experiencing is equivalent to that in terms of the kind of harm it is. And also he points out that 1 in 5 adults now, so 20% of adults in the United States, and more than 1 in 3 children, so more than a third of children in the United States, are living with a mental health issue, making the need to respond to the loneliness and isolation all the more profound. He talks about the need for the social connection. And, I think I was at an event last night, and it was one of the first times we'd been at this event in person in a number of years during the pandemic. And people were talking about how people have sort of forgotten how to interact socially. And there's still, obviously there's people who have health issues and compromised family members, and they're still a little bit nervous. And people are just a little bit more reluctant to make that connection. And the fact that everybody became so much more dependent on their devices during these couple of years has increased people's involvement in that and really dropped the social connection. The Surgeon General really laid out a framework for a national plan to go forward in building our social connections. And it's built on 6 pillars. One is strengthening our social infrastructure, which is really about designing places in our communities, whatever our community is, designing places where people can come together, whether it is in our communities like parks and playgrounds, whether it is in our buildings, open spaces, food areas where people can come together, adopting public policy that really encourages those kinds of connections. And one of the things that so affects people on this call, he talks about mobilizing the health sector to help, particularly with people they're treating, with patients, whether it's in a nursing facility or some kind of hospital or whatever, greater social connection. Also, he, not surprisingly, talks about the digital environment and how we address that, particularly with kids. And he is committing much more in terms of resources for research on that social connection issue. And then thinking about what are the informal things, particularly things we might have lost over the pandemic, just in our neighborhood, in our towns, those kind of informal connections. We've all really gotten in the habit of picking things up at the window, driving up and getting things at the curb, all of those kinds of connections that you don't have anymore, maybe banking online rather than going to the bank, those sort of things. I'm really hoping that as we look going forward, not just at these overdose deaths, but these folks that are dying by suicide with the use of substances, that we can really commit ourselves here to thinking about that. And enhancing the culture of connection. You're going to see one of the things we're doing in this office is we're going to be rolling out a new initiative in the next couple of weeks around Let's Connect benches, actually physical benches for places where people can hopefully spend a moment and just connect a little bit. We'll be putting out a lot more about that. And I also really want to leverage in doing that, the intergenerational communities we have. As I've said many times before, Massachusetts has a higher than the rest of the country percentage of folks over the age of 60. So our population is skewed in that direction, which is a good thing because it means people are being able to age in place. But in Middlesex County, given we're already above the national average, Middlesex County is further 10% more than that. So our communities skew towards that older age. And then we have the 21 colleges and universities. So my hope is to really foster that intergenerational kind of connection. In addition to the sort of mental health awareness piece, I want to say a word about xylazine. We just held a training for our police chiefs, officers, and other law enforcement partners. We're going to put the link to that training in the chat for people who are interested in that. And we are going to host a training on xylazine for this task force with Dr. Jawa, a training that she leads on the physiological effects, the manifestations of xylazine intoxication and overdose, the infections that are associated with xylazine. If you're not familiar with it, one of the certainly most obvious physical signs of the use of xylazine is the lizarding of skin on people, really terrible lizarding, and unique to many other drugs, that lizarding appears on people's body in places away from the injection site. So with most other drugs, if you're injecting into your arm, for instance, that's where you may see that skin distortion. With xylazine, you may be injecting into your arm, but it can appear anywhere. So you might be injecting into your arm and suddenly you've got a massive leg infection. So it is not connected. It's very different from other things. And also, particularly for those in healthcare, she'll talk about the wound care that's really necessary for people to save the limbs that they may see be infected. Dr. Jawa is an assistant professor in the Division of Internal Medicine and a clinical investigator for the Center for Research on Healthcare at the University of Pittsburgh. She's board certified in both internal medicine and infectious disease and addiction medicine. And she's really studied one of the other issues that keeps coming up is harm reduction services for folks struggling with substance use disorder. She's helped to develop some multidisciplinary providers strategies for diagnosing, preventing, and treating infections. So she studied at Boston University School of Medicine and is happy to come back and do this for us. It's an hour-long training, and we're going to schedule this in the time between now and our June meeting. So we will get that out to you as soon as we confirm that date. As we talked about last meeting, the Federal Drug Enforcement Administration has issued a public safety alert, again, about fentanyl mixed with xylazine. We are seeing that as well. Reports indicate right now that roughly 25% of what is on the street that people are buying has got xylazine in it right now. So, which is, as we talk to people, that means probably 1 in 4 of their purchases, they're going to get some xylazine. So we've invited the senior policy advisor in the White House Office of National Drug Control Policy to join us at the next meeting. He'll talk about the national strategy. And so that's kind of what we have coming up. But to today's meeting, we're going to begin with our first presenter, Joan Taglieri, who is the Senior Director of Psychiatry for the Cambridge Health Alliance. We really welcome Joan, who serves as a member of the Mystic Valley Regional Behavioral Health Coalition with our office. For 20 years, Joan's been serving as the Director of Clinical Operations in the Division of Psychiatry for BU's School of Medicine and for Boston Medical Center. We're grateful to have Joan here with us today to talk about that recently launched community behavioral health centers from Cambridge Health Alliance's perspective. And we mentioned this at the last meeting, this new model of behavioral health care is really looking to expand access to routine, urgent, and crisis treatment for mental health conditions and substance use disorder. And the idea is to have it be local access. So they are available, they're equitable, and they're rooted in our own community. So Joan, welcome. Thank you for being here this morning.
Well, thanks so much. I appreciate the invitation and happy to come back anytime to do updates. So I think probably most of you have some idea about what the Community Behavioral Health Center initiatives is all about. It's really the centerpiece of the state's roadmap to improve behavioral health care in Massachusetts. It's been, access has been a problem. I think probably most people on this call know, for a long time. Access to behavioral health care in general, whether you're someone with a substance use disorder or a psychiatric disorder or both. And that just got worse over the course of the pandemic. Just for instance, what we've seen with kids is, really a huge increase in anxiety and depression, because of disruption, right, in everyday life and school life and supports that they relied on. But the same is true of adults. And for kids, one of the things I heard about recently from schools are, this anxiety and depression is showing up in a couple of ways in the school setting. One is truancy, where kids literally are not showing up, that the stress of showing up really has become too much for them to handle. And again, worsened by the pandemic. Um, the other consequence for many kids was an increase in aggression. And again, for really probably the same roots, cause roots, right? Depression, anxiety, isolation. So it comes out in a couple of different ways. And it really is what we have to pay attention to in order to figure out what's going to be helpful um, to kids in particular, but to adults, which are really the numbers, obviously, for adults are far outweigh the numbers for kids, both in terms of psychiatric illness and substance use. Um, just to tell you a little bit about, so CHA has been named one of the designated community behavioral health centers in Massachusetts. There are 25. Each is responsible for a certain geography, responsible for delivering behavioral health care. And for CHA, I'll just pull up a slide if I can share that. Um, Give it a shot here. So, um, so for CHA, the geography is basically the communities of Medford, Malden, Everett, Cambridge, and Somerville. And we are, as of January 3rd, we opened our first site, which was on the grounds of Cambridge Hospital. And at that site is all the required services under the CDHC designation. And that's basically crisis, urgent, and routine behavioral health care for all ages. Um, and so on January 3rd across Massachusetts, January 3rd, 25 CBHC sites opened 7-day urgent behavioral health care. And I think that really, from my viewpoint, met one of the key goals of the state's intention, and that was to open access, uh, greater access for anyone who needs it. So 7 days a week, Monday through Friday, 8 to 8, Saturday and Sunday, 9 to 5. Every one of the CVHCs in Massachusetts has that footprint. And so I think access increased dramatically. And I'm going to show you a slide of what the activity level has been like for CHA. But I also want to talk about, while we started with establishing one of these sites on the grounds of Cambridge Hospital, we also, in order to better serve the communities of Malden, Everett, and Medford, we're going to open a second site in Malden, and we're going to open it by the end of this calendar year. And that will have the same set of services. It will have an urgent care center 7 days a week for those same hours of operation. It'll serve all ages. It will serve people with either substance use or psychiatric disorders or both. And so that, I think, is one of our, big efforts for the next 6 months, is really preparing for that opening. And I think we wanted to do that to make these services much more accessible to those communities. We see a lot of citizens from those communities now in Cambridge and in our Somerville sites. but I think we can do better with access by, creating this second site. So I'm happy to keep everybody posted about that. I just show you, we created business cards, which can everyone see these? I'm sorry, I didn't.
Yes, yep.
Yes, we can see them.
Okay. We created business cards, and these are in 7 languages. And I really hope you'll, email me directly and let me know if getting a supply of these would be helpful for the work you do and for your communities. Again, we have them in 7 languages, and we're happy to distribute them widely because we found that this has really been helpful for people who have no idea what to do in a crisis. I think getting this kind of information out to individuals and families and their caregivers and providers has been, extremely helpful. So I would like to just show you some data from January 3rd through April. And then I'll stop and see if you have some questions for me. Let me just share that. Is everybody able to see this?
Yes.
Okay. So this is our entire volume, and that means it includes crisis visits, it includes urgent care visits, and it includes new outpatient volume. So these are pretty big numbers. And so one of the things that makes me wonder about is this pent up demand? Are we going to continue to see, this kind of need into the future? So we're really trying to track our volume, and again, to understand who's using our services, how are they using them, as well as what's been effective. So
Oh,
I
hi,
just,
Joan. Sorry to interrupt you. I think do you mind going to slide 3 so we can see the graph?
oh, I'm sorry. You
Oh, no
can't see
worries.
it?
I think if you go up one slide, do you maybe click on 3?
I did. It's not apparently working.
Oh, okay.
Let me see if I can switch it over. Can you see it
There you
now?
go. Yeah,
Okay. All right. Sorry. So
that's okay.
let me just stop there and, see if you have some questions. But as you can see, the numbers are big. And let me just show you some numbers around kids and adults. Is everyone able to see this one?
Yes.
Yes, yep.
Okay. So, again, obviously we see more adults in total typically, but I think the only reason in my mind that February and April numbers for kids look less or are less is because you have school vacations in both those months. So I think it just kind of tells you how much the school factor can be stressful for a lot of kids. So let me just stop for a minute and see if I can take any questions.
People have questions for Joan? Comments? You know what, Joan, can you, oh, there we go. Okay, because I can't
Okay,
see
sorry.
the other one. Okay, no, that's okay.
I can, if you have a few more minutes, I'm happy to give you a little bit more information. Like
Sure, go ahead.
one, I don't think we're seeing enough of the folks with substance use problems using our services. And that's a concern. And so Not sure how to explain it, except that some people haven't, people haven't found us yet. Again, it's another reason that we are, hopeful about establishing a Malden site to really get to, more of the folks in those communities. We certainly, in our Everett Emergency Department, we see huge numbers of people with in an acute stage of their substance use um, uh, disorder, and so we're hoping by having an urgent care center, there's going to be a real good alternative to trying to meet some of the needs before people get to the point that they need an emergency department. So that's one of our key goals. That's one of the state's key goals, is to try to reduce the reliance on emergency departments for behavioral health care. And that is what's been available in off hours, even any hours. Where do people go? They go to the ED when it's a crisis. The police bring them there when it's a crisis. There's really not been an alternative. So I think this is a big step in the right direction. I
All
don't
right,
know.
so we got a
who's
lineup
up
of
first.
questions here.
Yeah.
Mike, okay, Eileen, it's nice to see Eileen here. You have a question?
Hi there. Yes, I wanted to first thank Joan, because she's been wonderful, and she's been out to our Malden Opioid Task Force to talk about substance use, especially for this group to be using these behavioral health. And I do think, Joan, once you're open in Malden, that will make a big difference, because we have heard that transportation. But actually, I was expecting that we'd start to see some decrease in the emergency rooms, and we really haven't. So I think you're right. We've got pent up need. We've got need that we weren't serving, but on any given day, we're still seeing 500 to 600 people boarding in the emergency departments across the state. So concerning that even with this
Right.
one service.
Well, Eileen, I think that there have been a significant increase in psychiatric beds, right, in the Commonwealth, and certainly CHA has been part of that. And that has changed the boarding, I can tell you, in both our Cambridge and our Everett EDs, significant, so that we're getting people into beds as they need it. But on the detox side of things, I think you probably already know this, but there's been a decrease in availability of services, detox services. And I think that has terrible consequences for the people we serve, right? So they end up in an ED, and then they end up out of the ED without really the level of care that they often need.
And I think this is a whole equity issue, because the cost per bed is gone down for recovery beds and for detox. And my daughter-in-law works for Gosnold. She's a director of nursing down the Cape, and just how do they keep these beds open if they can't get a reasonable rate for the patients? So that's
I totally agree with you. I think it has made a huge difference and a huge consequence. I happen to be a nurse, a psychiatric nurse, and so I know that several detoxes have closed because they can't get nurses. Why? They can't compete salary-wise. That comes from poor reimbursement for services. It has that trickle down effect, right? So I do think that's a pretty bad situation.
And I know our hope is with the Malden Hospital coming with Acadia, that it will be a pipeline program. We'll be training for Tufts Medical School for our nursing programs. So we'll start to see more people, but we definitely need more students, and we need to have more practitioners. And there has to be a more fair and equitable pay. Nursing has a much higher pay than, say, does social work. And it's hard to get people to go into a profession that's so overwhelming, I would say, given the amount of violence and things we're seeing, and then not be paid well. So I thank you. I don't want to take too much of your time, but thank you, Joan.
I totally agree with you, and I'm hoping the advocates are all over this.
All right, Jackie.
Thank you. Joan, my question is more that you were saying you don't see a lot of substance use. We've had people brought to our CBHC, but because it's a selection, if they say they don't want treatment, then they're released. And that happens a lot. So I don't know where they fall as far as a head count. That's what we say.
Yes, I mean, most care is voluntary, right? And we want it that way, but we lose some people who are particularly, really in really acute states of illness. And CBHCs are not set up to deal directly with people on an involuntary basis, right? That still ends up being what happens in an ED. But what we need to do is get to people more quickly, right? And so again, one of the centerpieces of this program is open the door and let people just come when they need to. Don't wait till people are so sick that you do need an ED, right? And so one of the things that we found in our urgent care is we encourage people to walk in. Don't wait, to try to schedule a visit. I mean, you can, but that phone tag issue is real. We found ourselves in the first month in January. People leave us messages wanting to make an appointment. We call them back. They're not there. We leave a message. They call us back, and we end up not providing the needed care. We can still do scheduled appointments, but we have, our message to people is just come. Just come. Here are the hours. No questions asked. If you're in crisis now in the state of Massachusetts, right? Crisis services are available regardless of insurance, regardless. And the person themselves can name it a crisis, and the services become available. And so what's one of the lessons we learned is don't try to schedule everything. Let people do what they can when they feel the need, and then get things started. We certainly lose people, just I think as you're alluding to, because it's voluntary, but having recovery coaches at the front door and having better engagement with people with SUD, you know how important that is, right? And that's one of the members of our multidisciplinary team.
Sheila.
Thanks.
Hi,
Let's see. Hi, Joan. Let's see. I was really surprised by the high numbers. I think it was on your second slide, and I think with the different types of evaluations. And are those unduplicated counts in each of
Well,
those?
no, I can't say that. I mean, some of the visits are not our same person, right? But mostly it's individuals are represented there.
Thanks.
So, Joan, there's a question in the chat about whether the website lets people know that they can do a walk-in.
I'm going to have to check that out myself to make sure it's prominent. I will do that. I actually can't remember now because I haven't looked at it in a while. But please tell people that. And again, we'll try to make sure we're better at saying that. One of the things that was also established is every CBHC has to have a 24/7 call service, right? And I encourage people to use that for anything, literally. Call, even if it's routine care you're looking for, you're moved from out of state, you have a problem that needs some continued service, call that number. You need a consultation as a provider. That's master's level people answering the phone. Call that number. What do you think about this particular circumstance? Or a family calling. What do you think makes sense? This is what I'm seeing. This is what I'm hearing. This is what I'm worried about. Or the person calling themselves, even better. So not just a crisis line, though it is a crisis line, which means if that triage clinician determines that it's a crisis, we're going to respond in some way within the hour. And there are several options. One is the mobile team. We have a much more active mobile team now in the community. They can see all ages, they can see people at their homes and in schools, and that is our preferred way to respond to a crisis. Another option is, again, just have people come in to the urgent care. So that crisis line, again, is an entree to whatever is needed for a particular person.
So apparently Sabina tells us it does say on the website that you can be a walk-in, which is a good thing. And Doug, do you have a question or comment?
No, I was just going to let people know that I did post the website in the chat, so they can certainly
Oh, hi,
pull it
Doug.
up that way. Hi, Joan. I will see you a little bit later.
Yes.
But it is posted on there, and yes, it does state that walk-ins are available at the CPHC.
Okay, great, thank you. Any other questions? Anybody I'm missing? I think I can see everybody. All right. Joan, thank you so much.
Oh, appreciate it.
Those are great resources. Thank you.
Thank you.
All right, and now we're going to turn to another of my old friends. Bob Cox is here from the Bridge Club of Greater Lowell. As many of you know, the Bridge Club is a 501c3 nonprofit, which has as its mission providing a safe place for those in recovery to meet, but they're really doing so much more than that. They hold multiple NAAA meetings throughout the day, 7 days a week, 365 days a year. They have a staff of dedicated recovery coaches ready to help people either navigate recovery or come back from a relapse. They assist in detox and rehab and sober living placements. And they're really doing so much work. And Bob and I have been talking lately about some additional projects and helping people get into the workforce. And we just heard an update from Bob, our team, on some new programming around homelessness and other ways to bridge that gap. And we invited him to come update us on what was going on. So Bob, it's over to you. Bob, you mute.
Great. Thanks, Marion.
Oh, there we go.
Thanks,
Okay.
District Attorney Ryan. Appreciate the opportunity to be here today and present. For those of you who aren't aware of what the Bridge Back Initiative is, it is a collaboration of District Attorney Ryan's office, Middlesex Sheriff Peter Katujan, and the Bridge Club. And it is a reentry program aimed towards anti-recidivism. It was founded in early stages. It was through a discussion with the district attorney and myself. So we're going to go right into the slides. I'm going to take you through a slide presentation to give you some timelines and some things that have transpired, what it was and what it is now. The Bridge Club of Greater Lowell, as I just explained, very, very proud of the Bridge Back Initiative. It's something that it's been the cornerstone of our existence actually for the last 2 years, something we had not planned on. I don't know if you can call it a gift of COVID, but it was certainly a product of it. So we're just going to go through the agenda that we've got here. It's not as daunting as it seems. Got a quick introduction as we're in right now. I want to show you the areas of focus that we've established, the timelines, the Bridge Back Initiative employment, the transportation, the housing, and the summary. So next slide, please. So the introduction is the Bridge Back Initiative assists court-involved individuals by connecting them with employment and other supportive services. Bridge Back Initiative is a collaboration program where individuals are screened to identify those who would benefit from employment opportunities, substance use disorder and recovery-related support, and other community-based services as part of the disposition of their underlying criminal case. Bridgeback Initiative, the areas of focus. This is basically what the Bridgeback Initiative offered in 2022. The recovery meetings and the coaching is the cornerstone of what we do, and everything basically that we do, the programs that we do within this building, I view them as a means to an end. Obviously, we all need money to make our operations run, and the means to the end, our end result is to keep the doors open for people in recovery. So obviously, we need money to do that. The Bridgeback Initiative, as people are being released, we'll just use the Billerica House of Correction, for example. They're able to walk through the door here, receive free clothing. We have people that get off the bus directly from Billerica wearing their prison outfits, if you will, clothing issued that from the prison, able to get a free clothing here, sit down, do a Bridgeback Initiative intake form, at which time they're exposed to various employment opportunities that we have. We've identified to date a number of Korean-friendly employers who are willing to overlook past indiscretions, gaps in resumes, and they know people are coming through the prison system, but they're willing to give people the opportunity of a second chance in life. Realistically, it's a good move on their part because for a long period of time, it's been an untapped resource of available people, especially after COVID, when a lot of the industries were so shorthanded. It's bode well for this program. One thing that has, by far, in my opinion, set the Bridgeback Initiative aside from other programs is the fact that we offer transportation. That was something that, whether it's Mass Hire or some of the employment agencies that we've dealt with job fairs and things, transportation is the underlying issue that has plagued almost every industry for, I think, years and years in the past, and it's certainly present now. It's not unlikely for someone in the community that we serve to not have a license for various reasons, obvious reasons, drunk driving, accidents, what have you. But licensing is certainly an issue. So the transportation is one of those obstacles that the Bridgeback Initiative removes. It allows people to keep more money in their pocket. Newly employed people coming out of jail, their money actually means more because they're not wasting it on insurance and gas and cost of the vehicle and everything else that comes along with that. And as we're going to talk about as we go through, we've added a new component, which is the last phase of this chart, which is housing. So next chart, please. Okay, this is the Bridgeback Initiative first year timeline. Let's go right through it. November 23rd of 2021, the infamous phone call I get from District Attorney Marian Ryan, who after a couple of phone conversations about an anti-recidivism program, told me she had found a potential program, which was the Community Empowerment and Reinvestment Program, doubly named the SERP grant. And we were notified, and I believe the conversation was, this might work, but you have like 1 week to get the paperwork in, which was exactly what it was. And if you notice the timeline, November 23rd, she was kind enough to give us 2 days before Thanksgiving. So the grant writer and I, as I recall, some sleepless nights, and we were able to get the grant in on time on November 30th. And just 30 days later, on December 31st, we were notified that we had in fact received the grant. So at that point, we were awarded $352,000, which basically is interesting to note that the SERP program, for whatever reason, is runs on a 6-month schedule. So the funds that would become available in a perfect world in January 1, we needed to have spent by the end of June for the fiscal year reasons, obviously. But it creates a little bit of a time crunch and also a void at the end of that period. So February 1st, because we had notified people that we had this grant coming, word spread pretty quick, especially within the Billerica House of Correction. We have a lot of contacts within that jail. And on February 1st, we did the first ever Bridge Back Initiative intake and job application. Someone came directly from Billerica, walked through the door, and that was our first client basically for the program. A few weeks later, on February 18th, we received the funding. And then through the next 6 or 8 weeks, we were able to obtain a vehicle and started transportation on May 24th. From May 24th to October 3rd, 5 or 6 months, we had our 100th client intake. So the program was really bearing fruit almost immediately. Part of that was because simultaneously and through a whole different program, we were able to secure a very small grant through the sheriff's office. And we were in the prison doing wellness workshops twice a week. People from the Bridge Club going in, doing wellness workshops. We're doing things like motivation to change and a lot of the recovery coach service criteria with the inmates still incarcerated, talking about credit repair, real life things that they would help them when they get out. And it really caught on. So there was a line coming through the door, it seemed, for a while, coming directly from Billerica. And then fast forward to December 29th, we had our 1,000th client transportation. Important to note that that is not round trips, that is a one-way, but still, you're looking at 500 round trips to and from work from the Bridge Club, free of charge, by the way, to not only the employee, but the employer. So, they're getting help, much needed help, and they're getting it basically guaranteed because we're on schedule. We make sure we're on schedule. And so they're almost guaranteed that their people are going to be on time. Next slide, please. Bridge Back employment applications submitted, a breakdown by quarter. It's the number of the quarters that started to go through. At quarter 2 of 22, we took in 35. It slowed a bit in quarter 3, 14. Now, a lot of these applications, as you see, the reason for this drop, part of it, and it'll be reflected in further slides, is that we were basically taking anybody that would walk through the door, and request our help. We would sit them down, talk to them about the employment opportunities we had, get a job application, and without much further in-depth discussion, we would set them up with a job interview. So a lot of what happened was people would come in, they'd get their free clothes, they'd appease us by filling out the Bridge Back Initiative, and they'd disappear into the abyss, never to be heard from again. So we would set these job interviews up with the employers, and it reflected poorly on us at the beginning. So what we had done is we made it a 2-part session. We had them come in, fill out the paperwork, come back the second day to complete the application. And at that time, we would set them up with a job interview, just so they had some skin in the game. And that's, I believe, is the reflection of that number dropping from 35 to 14. That trend continued into quarter 4. And then quarter 1 of 23, it started to incline again. Go ahead to the next slide, please. So 87 applications to date. Bridge Back employment breakdown, as you see there. A lot of times people will come in and, our job actually stops once we have taken in all of the information, got them the employment, and we can bring them to and from work. But once they're there, we can't control their job performance. We can't even control whether or not they're going to show up for work to get a ride. So for various reasons, people fall off the scale. Could be anything from they find a better job. I mean, I jokingly said when we were talking about this prior to the presentation, it's not like we're offering, astronaut jobs here. These are warehouse jobs. Granted, it's employment, and I don't belittle those jobs. However, it would not be unusual for someone to find a better position somewhere else, given the opportunity to search. So that's reflected in some of these numbers, where people just find other opportunities, or unfortunately, this community where we all deal with, people relapse. It's part of the world we live in. And unfortunately, that's reflected in these numbers as well. So go to the next slide, please, Brad. These are the transportation numbers. This is actually kind of impressive. I kind of opened my eyes when I saw that final number, and that is actually transportation runs through March 31st of 23. So we've got all of April and part of May that's not reflected in these numbers. And what you'll see is those numbers, they vary slightly. Part of it is, as I mentioned earlier, our funding for this program came to a halt. Actually getting funded through the state came to a halt at the end of June 22. So that being the case, we were faced with, we either stop the program or we find a way to continue it. My fear is if we stopped it, we would lose all credibility with the employers that we had given our word we would transport these people, and we would never get it back, or it would be a mountain that was too hard to climb to get back. So we decided to self-fund it through various donations and fundraising activities. And at one point we cut our staff 60%. And people sacrificed and whatever, we made it happen. Because of that, result would have been tragic, I think, if we gave up on it. And thank God we didn't. So if you look at the end of that number, that 1,742 transportation runs, I was impressed with that when I saw it, I have to be honest with you, as of March 31st of 23. And that's from dedicated staff of people that get it and understand that they're showing up on time. They're making sure that their steadfast reliability is in place to make sure that, because of the importance of what we're doing here, we're driving people to work so they can support their families or themselves. This isn't just any kind of a joyride here. This is important stuff, and the staff takes it seriously that way, and I'm very proud of them for that reason. Let's go to the next slide, Brad. Thank you. The fiscal year 23 timeline, December 1st, and I will say that I mentioned transportation kind of set the Bridge Club, I think, aside, the Bridge Back Initiative aside from other programs, and the fact that a lot of people were taking the transportation on. That kind of was a highlight for us. I know that in fiscal year 23, that has switched over to housing. Housing has become a huge part of this. It's been a wonderful thing to be involved with, to be able to see these people come through and be able to help them, because part of the issue was, yeah, it's wonderful. We're driving people to and from work, and it's great. We're giving the opportunity they can make some money, and we're saving them all kinds of money. But, we were seeing in a lot of instances, we're taking people home from work after working 8, sometimes 10 hours a day, and they're going home to the shelter, or they're going home and they don't have a home to go to, and they're wondering where they're going to sleep that night. So it obviously was a glaring void that needed to be filled. So we actually applied for another round of SERP funding. And in December of 22, we realized that we got the grant award notification. And at this point, we had requested an additional $80,000 specifically for housing, which we got. So our $352,000, actually with a couple of other additions, was raised to $450,000. And that budget for housing included sober housing and market rate units, where we would supply 100% of their housing costs for 3 months, providing they were working, enable them to save enough money at the end of the 3 months to take over the payments for either sober or market rate housing. And it worked out great. And early on, in the onset, again, we realized that people coming directly from jail hadn't had the opportunity to make arrangements with sober housing. And the void in the system was we didn't have access to people coming out, so we couldn't make arrangements for them prior to them being released. So they're coming out basically in the same situation they were before, where they don't have a place to live. They're either, going to sleep on someone's couch, or they're going to the shelter, or they're homeless. So we made an amendment request to the state Executive Office of Housing and Economic Development for $21,000 to be used in emergency same-day housing. which would allow us to put people up in a hotel for 3 weeks, up to 3 weeks. That amendment was approved, and that has worked wonderfully. The Middlesex Sheriff's Office on Summer Street, which is where a lot of the people will go directly coming out of Barica. People go there looking for the same help that we give, and especially people who have no place to live. And so Joe Iannello over at the Sheriff's Office has done yeoman's work, directing people to us. He's a wonderful guy anyway. He does great things with people resource-wise. I know Rita's on here, so Rita, make sure you tell Joe we threw him a bone. But he really is. He does great work. But Joe has been instrumental in steering people to this program in order to get them a roof over their heads the same day. So that's usually effective, and going to be a steadfast thing that I think the Bridge Club is going to be holding on to for quite some time. So fast forward, January 27th, the grant contract was finalized with the housing amendments and signed and returned, and we received funding in February. From February 10th to March 31st, we had put 16 people in housing. That's 16 people that would have been either homeless or living in a shelter. And then just go March 31st to April 20th, not a long time here, just 3 weeks. And that number jumped from 16 to 27 clients that were housed by April 20th of 2023. Go to the next slide. This is the housing, how it's broken down right now. In 23, 27 individuals received housing funding, and that's the combination of the sober housing, the market rate, and the emergency housing. We've got 22 people on waiting lists, which speaks volumes to the need. Just speaks absolute volumes to the need of housing for these individuals in reentry. The individuals received housing number is 27. Proud to say it's going to jump to 29 as of next week. We have 2 other people that were able to squeeze into the budget, and they'll be 20. That number will jump by 2, and those will both be market rate units. So it'll be a total of 51 applications total. And that's in my opinion, that's a great thing that we're able to do. Thank God for the funding from Executive Office of Housing and Economic Development. Go to the next slide, Brad. Okay, the housing recipients breakdown, again, I just went over that. So we've got 16 people in sober housing, 6 in market rate, soon to be 8, and 5 in the emergency housing. That emergency housing, we still have enough funding in our budget to carry 5 more and stay within the budget. So that's going to get eaten up very quickly. But that's where the numbers stand right now. All right, this is a flow chart of the Bridge Club of Greater Lowell in 22, an operational diagram, if you will, and it basically is self-explanatory. Shows the bridge back at the center. Off to the left and upper left is the clothing. Obviously, the bottom left, the Corey-friendly employment, which is at the heart of it all. Recovery coaching and meetings up to the right, and the transportation, which ties it all together. So that's what we were in fiscal year 22, and the next slide will show where we're at in 23. Okay, so I think what happened in a lot of instances was a lot of the other organizations in the area, nonprofits, saw what was happening here and realized that their clients, I'll use Thrive as an example, their clients could benefit from our services. So like Thrive, a lot of other organizations were reaching out and try to collaborate with us, which is wonderful because it bolsters what we're able to provide and also bolsters what other organizations are able to provide. And that's really what it's all about anyway. So just to run you through this real quick, the pending programs off to the left, we're going to leave that for the last, but Bridge Club is obviously at the center, straight up and above. Dead center is the bilingual recovery coach training. Just real quickly in that, recovery coaching became a gift of COVID. We were looking to something to do when the meetings kind of ceased to exist until we really started to catch steam. So we realized looking for grants that English as a second language is a recurring theme in just about every grant request or grant application we could find. And that shed a light on the program. The various demographics of Greater Lowell lent itself to the fact that if you struggle with English as a language and you're in recovery and you need help, you can't get the same recovery services. You don't have access to them that I do and that you do. And that became evident. So we reached out to many of the communities, three of which being the obviously Latino community, the Cambodian, Southeast Asian community, and surprisingly, the African Swahili speaking community, Gordon Holm and his group. And we launched a program called the Bilingual Recovery Coach Program, where we're training, we do training right here at the Bridge Club, but we're training people in English. If they're bilingual, they can then learn the skills in English and take them into their own communities. As of the end of 2022, we had trained 100 recovery coaches at the Bridge Club, and we've done 2 classes consisting of about 30 people in the first 2 quarters of 23. Off to the left and down is what we mentioned, the sober housing and market rate, with the key cleverly disguised there from Bradley is the emergency housing. Bottom left, we'll skip over the pending. Bottom left, the clothing, the Corey-friendly employment. Let's go back up to the upper right where it says MAT clinic. The medically assisted treatment clinic is one of the pending programs that's coming into the Bridge Club, where we're going to have a primary care physician and a psych MD on staff 5 days a week. They'll be able to do referrals, become a primary care physician if someone doesn't have one, and also dispense medications. That's going to be coming. We were hoping for July, but it looks more realistic like September of this year. We'll skip right over the recovery coaching and meetings. Part of what we're able to offer here, because of the collaborations we have mostly with Mass Hire and through ATR, is vocational training. Now that's vocational training outside of the building. Things like tradesmen, plumbing, HVAC, programs offered by both Mass Hire and ATR. But the in-house vocational training that we have to offer is obviously the bilingual recovery coaching and regular recovery coach training. That is a vocation. People that are in recovery or not really, and they don't necessarily have to be in recovery, can take advantage of working in the industry should they so choose. And we can train them right here. We've got 8 certified trainers at the Bridge Club. One of the programs under pending, which I'm extremely excited about, is the culinary training program. My wife and I actually own a restaurant and have for 22 years. When we opened here, we figured that culinary would be a great opportunity for people in recovery to jump back into the workforce. So early in 2020, before COVID even hit, we had secured $50,000 from the state of Massachusetts for equipment for a kitchen. So we furnished a brand new kitchen, and then COVID hit. Now I've got fry laters here that haven't had a drop of oil in them. And my whole theme right along was, it's going to happen in God's time. And I think God's time must be now, because we've found a program, identified a program that fit what our hopes were, to find like a 13 or 14 week program that would produce basically a line cook. The restaurant industry in Massachusetts right down 60% of the restaurants in Massachusetts by the information that's published are down a minimum of 1 line cook. This program is being operated right now through a program called Roots North Shore out of Salem, Mass. And it's exactly what we want. They were great. They're a nonprofit themselves. They've shared their curriculum, their entire program structure, which we are going to copy. We've identified a chef, a training chef that's going to take the program over. And we are already enlarging our kitchen to accommodate the program. So this will be coming up as soon as we can fund it. I'm hoping, I don't think it'll be in July at this stage of the game. I'm hoping by September again. So these are all great programs. And again, culinary training is going to be a vocation that we can offer to these people in reentry as well. So you look to the left, it's under the pending programs, in addition to the ones I just mentioned. A license fee forgiveness program is going to be forthcoming. And District Attorney Ryan and I had spoken a couple of years back, and she was talking about a program that she was looking into about people who had built up all kinds of fees and penalties because of loss of license. You know, obviously it's a recurring theme, and what happens when they get penalties and fines is there's obviously interest that accrues on that. So, you know, it becomes an insurmountable mountain to overcome, basically, because people are coming out with thousands and thousands of dollars sometimes, especially after spending time incarcerated, where they're unable to do anything about their bills. And her whole theory was to find some way to finance that with the cooperation of the RMV. To take a page out of that book, we had run into a situation where a gentleman was stuck on a $400 bill from the state of New Hampshire and a $400 bill from the state of Massachusetts. That was a stumbling block for him to get employment, and not so much employment to transport himself, but to obtain an ID, a license, in order to get that employment as a form of identification. Now, in Massachusetts, you can get a real ID, especially now with the advent of the need to upgrade to a real ID. There's other qualifications, birth certificates and things like that, that have to be obtained. But we realized that that gentleman was just that for $800, you know, was keeping this gentleman from getting a job, and it was potentially putting him back in a situation where he's going to fall into the whole recidivism issue. And in conversation with someone from the MSO, you know, this happens all the time. So we are going to be looking at putting in as part of our next and future grant requests, a slush fund, if you will, that we can use exactly for that. So we can just take that stumbling block right out of the way. I mentioned the culinary pilot program. The next one is the reentry apprenticeship program. This is a product of a separate grant that we wrote, which is basically the Bridge Back Initiative specific to veterans. And it's incarcerated veterans rehabilitation program. And there's a grant pending right now, and program is called Hire a Vet. And that it's going to be brought over into the non-veteran status as well. And basically what that is the Bridge Club will and has identified 4 employers who are willing to participate, where the Bridge Club will give a client a stipend of $10 an hour, providing it's matched by $10 an hour by the employer, giving this, obviously, the employee a $20 an hour stipend. We'll carry that for 90 days. At the end of the 90 days, the employer has the opportunity to have seen the employee at work, make the determination, and hopefully hire that person at no less than $20 an hour. So that program opens up some doors in various industries: automotive, manufacturing, culinary, and also construction. Some of the local construction companies are willing to do this program. So that, I mean, that in itself will give someone the ability to learn a program or a skill that will carry them through a lifetime. The last and actually most exciting thing, which I think is going to be part of our highlight of 23-24, is the continuing education program. It's just another component of someone coming out of jail. They don't want to go to work. They don't want to take a vocational training. What about continuing education? So we're in talks right now, mostly with Middlesex Community College, which is basically a football field away from this building I'm sitting in right now. And Judy Burke over there is excited about this program, as I am. And we are going to work collaboratively to put together a program for people coming through the jail system, where some type of program will be acceptable to both the college and the person. We are in talks also with Lisa Aubin, who's the educational director for the Middlesex Sheriff's Office. They have a continuing education. I think it consists of, if you need your GED or equivalency, and then some type of college preparation. But my goal is to have both Judy and Lisa at the table to put the program together in the next month or so, where we have some kind of steadfast plan for someone who chooses continuing education as an option. UMass Lowell spoke to them briefly, and there would be a furthering option after those 2 options are exhausted. But that continuing education, stay tuned for that one. That's going to be a good one going forward. Next slide, Brad. All right, that pretty much going to summarize it. So basically, in summary, it's our mission here at the Bridge Club to help individuals rebuild their lives after they are involved in the criminal justice system. Through the Bridge Back Initiative, we offer a variety of services, including clothing, employment, transportation, rental assistance, and recovery-related services for substance use disorder. Next slide. I want to thank everyone for their time. Marianne, I want to thank you very much, District Attorney Ryan, for allowing us the opportunity to present. And if there's any questions, and if anyone sees anything that we're missing, if you see a void, we're all ears. We're looking to improve, so we'll take all suggestions anyone may have, appreciatively, by the way. And thanks for your time.
Thanks, Bob. Bob neglects to mention that I'm just the cheerleader. No matter what Bob calls me about, I say, that's going to be great. We'll just figure that out. We'll just build it and they will come. Two questions that people have put in the chat. Number one, this is actually an interesting question. Would you take people in this program from Framingham?
Yes.
As well as Billerica? And I don't actually even know the answer to this. Is it somehow being advertised at Framingham?
I don't know that it's being advertised as any one particular group of people or community. I know that, with the Middlesex County District Attorney's Office, obviously, and the Sheriff's Office being involved, people do assume it's Middlesex County only. We've had several people from Suffolk County and from Essex County that have come through the program that, have gotten employment here. Part of it is the housing. I mean, we're when we started to do the sober housing, all of a sudden there was a shortage of beds everywhere. And then all of a sudden people found out we were a funding source and they were beating a path to our door. So we went from 3 sober houses with maybe 60 or 80 beds to the availability of well over 200 beds in maybe a dozen or more sober houses, reaching out as far as Springfield. But through the advent of that, we've found people in the sober houses, for example, in Winthrop, that have been coming up for job opportunities. So there really isn't we don't put a timeline, not a timeline, but a geographic barrier on this at all. We never have.
Anybody? And just to circle back what Bob said, we have filed that bill again. Representative McGonigal from Everett is sponsoring that bill for us, which would require the registry to set up a payment program for people that if they have amassed a set of fines that would not let them get their license, that they would be able to enter into a payment plan of a minimum of $25 a month. And once they've got a history of making those payments, they'd get their license back. Obviously, if they stop making the payments, they'd lose their license again. It's a great thing, both for people who right now, as I mentioned before, right now, the registry will not take less than the full amount that you owe. So if you have $200 and you want to pay it on your $400 bill, they won't take that. So this way you can start to chip away at that bill. And in addition, it's good for everybody else because right now we're just not getting that money. So, and that's the money that goes for roads and other improvements. We're not getting the money at all because if you have your $200, they won't take it. This way we get the $200, we get people back on the road so they can, go to work, take care of their kids, do all of that. So, and the other piece that Bob and I are doing a lot of work on right now is trying to figure out some internship programs to longer term jobs for people. So that's another part of the plan. Anybody else? Questions, comments? Bob, thank you. This is all going really well. Thank you.
Thank
Do you
you
want to
very much.
mention the golf tournament? I want to give you that opportunity.
Absolutely. Thank you very much for that, by the way. Sure, that with Bridge Club Golf Tournament is this coming Monday. It's supposed to be 65 and sunny out. We do have openings. It's at Trellbrook in Tewksbury. It's supposed to be a beautiful day. So the dinner after is at Lindsay's. They do a great job. Anybody wants to play? We have foursomes available.
And what is it that people can win?
Well, we do have a $10,000 50-50 raffle, and we do have tickets available for that, actually. But but that is available as well. And it's 200 tickets sold, $100 a ticket. The winner takes 10,000, the Bridge Club gets 10,000. That's the deal. Thanks for letting me plug that.
Okay, so now we have an ad for you that Rita's just put in the chat that you are the best. But the one thing that I do want to circle back, and I am scared by this. I was in Lowell last week and they were doing a fundraising event which featured the glue that holds us together, Rita, riding on the back of a motorcycle.
I wish I had thought I would have posted the picture.
No, we're really happy you didn't do that. But Rita, I see you're still intact. I was very worried because had that gone badly, we would have had to be out there investigating it. So I was hoping that they rode quickly out of Middlesex County.
Thank you so much. This is a great organization. Thank everyone for listening to this presentation by Bob Cox. He's the best. I'm so honored to be a part of it. There's many more things that he could have said, but we would have been here for another 2 hours. So thank you very much. Thanks, Marion. You do a great job as well. Thank you so
Rita,
much.
I'm so happy to see you in one piece. As Mike
Me
Hugo
too.
says, people should stay off motorcycles.
I know they should, but it was for a good cause, so it was my honor. Thank you so much.
I think Paul Belay is still hospitalized from the wounds for her clinging on to him for dear life. I'm pretty sure.
All right. All right, we are reaching the end of our time, but I want to give David Hunt, told us that he attended the Zeroing In on Xylazine training sponsored by Boston Medical Center's Graken Center for Addiction Training. And he took a couple of minutes to think about what he took away from that training and he wanted to share that with you. So David, I see you. Okay.
Okay, you can give me on screen share. I made a couple of slides. I can do this real quick. Okay, here I am. I think it's coming on. Share. Okay, there's. Before I start, I want to do a special thanks to my friend Steve Morris, one of the members of this group, for putting this into a PowerPoint presentation for me. I attended the class. I was hoping other people from this group would be on it, but I have a lot I took away from it, and I put it in everyday language. I'm not speaking to doctors here. I'm not speaking to nurses, so everybody will understand what I have to say. So special thanks for Steve for making this possible and making it presentable. So the first thing is, obviously, I'm a member of Middlesex DA's Opioid Task Force. I'm also served with the Safe Baby, Safe Kid Task Force, Asian American Pacific Islander Task Force, Anti-Hate Discrimination Task Force. I was asked to do this in 10 minutes, by the way. Metropolitan Boston EMS Council Board of Directors, and on the Pre-Hospital Committee, and on the Mystic Valley Regional Behavioral Health. Can everybody hear me okay?
Yep, we're good.
Okay, okay. Next slide.
David,
Second.
click on slideshow.
Make sure, yep, make it a slideshow. And then
Slideshow.
over to from beginning, okay.
Now go back to slideshow.
Yeah, it didn't go to.
No, click
Okay, I can
slideshow.
do it this way. Okay, there are no conflicts of interest. The information I'm giving you is comprised from the FDA, the Mass Department of Public Health, the National Library of Medicine, which is a great place for everybody to get slides from, and from a webinar I attended at Boston Medical Center. Okay, xylazine. What is xylazine? You're going to learn, how does xylazine get into the user? How does he get it? Recognize the signs of a xylazine overdose, understands the risk of xylazine, recognize skin wounds caused by xylazine, and the proper treatment of a xylazine overdose. Okay, xylazine is an animal tranquilizer. It comes originally from Puerto Rico. Since 2010, it's been distributed through Puerto Rican sections of Philadelphia, and that's how it got its nickname, Trank. It's a tranquilizer. Over 90% of the heroin from Philly have xylazine in them. It's not found on its own. It's found mixed with an opioid or fentanyl. Xylazine is not an opioid. It's a muscle relaxant and a sedative. It is not for human use, therefore it's not a controlled substance. Why is it dangerous? It extends the onset of an overdose for a few hours. What this basically means, if we're in a group at a party and we all take an opioid and overdose, we're doing it in front of people. Family, friends, someone can call 911. With xylazine, that doesn't happen. It can happen on your way home while driving in a motor vehicle. It can drive when you're home. It can start when you're home in bed, and it releases all the power of the opioid at once. There's no one there to treat you. And the FDA is stating 1 in 3 fentanyl deaths have xylazine in them. Wounds. Wounds can start as a red or purple blisters. They can look like large sores or small ulcers. And like D.A. Ryan said, you can get that lizard or reptile look to it in a different part of the body from how it was brought in. It can spread over your body, covering an entire leg or an arm. It's horrible pain. Bones in the body become visible from the skin and muscle loss. The wounds are difficult to treat. They can result in loss of fingers and toes. I'm not going into the treatment on this little class for the level. That's all we need to know about it for the level of people in this room. Here's where the fun begins. Oh, warning, people, turn your heads away. Okay, warning. The following are very graphic. They may be very disturbing. The next 2 pictures came from the Library of Congress. They show a 37-year-old female in Philly who mixed 8 to 10 bags of fentanyl or heroin with xylazine, resulting in major damage. Now, until I come back on the screen, if you do not want to see the next 2 slides, this is your chance to turn away. I'll tell you when it's safe. Okay, that is the result of the same 37-year-old woman. This next slide, as you can see, it's gone through. It's almost to the bone. That's going to require an awful lot of antibiotic. Don't bother reading what's on your right. That's just permission to use this, showing that the National Library is allowing public use of these photos. How do you treat for an overdose? Very easy. First thing we all do on this level is call 911. Immediately administer Narcan or naloxone. Maintain an open airway, open mouth. If the person is not breathing, begin rescue breathing, which is 1 breath every 5 seconds for an adult. Make sure you pinch the nose shut. If you are a trained administrator of oxygen, administer it according to your state protocols or your city's protocols. And for long-term use is roll the patient to the opposite side every 2 hours due to the development of bed sores. How does Narcan work? This is a problem, straight out. You're going to have different versions depending on who you talk to. You may have heard Narcan is absolutely useless against xylazine because xylazine is not an opioid. That is sort of correct. Since xylazine is not consumed on its own and found with an opioid or with fentanyl, by administering Narcan, you at least release the opioid portion from the opioid receptor, and possibly the patient will revive now that the opioid has been removed. So forget about xylazine. Let's just go back to opioids real quick. Someone overdoses on an opioid, you give him Narcan, it releases it from the receptor, allowing the patient to start breathing again on his own. Unfortunately, if it's just xylazine, it will not work. But where xylazine is found with an opioid, you're at least removing one of the 3 factors affecting your patient. And this will wrap up real quickly. I had other slides, but again, for sake of time, we did not bring them. What are the signs of an overdose? I put this in everyday language so we can all understand what's going on here. You're going to have a slow pulse. If you try to detect a pulse, it's going to be slow. It's a sedative, so the patient will be drowsy. Slurred speech, may or may not know what he's saying. It may be slurred. Weak, very slow reflexes. You ask him to pick his arm up, it's going to come up very slow. You ask him to lift his leg, it's going to be a slow reflex. Low blood pressure. If you're licensed to take a blood pressure, you're going to see that's going to be a very low blood pressure because of the sedative portion of the xylazine. And there's a high risk of overdose. And our last slide, what are the long-term effects blood clots and skin ulcers, muscle and severe nerve damage, definitely kidney damage. Your kidney's trying to filter all this out and your body's not equipped to take out a tranquilizer. This is called Tranq, by the way, for vets, because it's used on animals, large horses and elephants. If a horse gets hurt in the field and you're trying to treat it, they'll give it xylazine to calm it down so the rescuers and vets can work on it. This was never made for humans. It was just another way to get a kick in there to increase the effects of the opioid or your fentanyl, because they're always trying to get that next big high. So I'm also, just to throw out there, I'm also the host of a television show on Woburn Public Media, America in Crisis, Breaking the Cycle of Addiction. 90% of my guests come from people who attend these meetings with DA Ryan. It's a way to showcase what your organization does and what your programs do. So I threw my email at the bottom, the dhrescue@comcast.net. If anybody out here wants to highlight the good work everybody's doing, I'm willing to listen and possibly feature you on one of my monthly television shows. And that's completely at no cost to you. So it highlights the efforts you're making. I want to thank DA Ryan and Madeline for allowing me to speak today. And this is just to tie you over until the people from Children's Hospital or other doctors or guests come in that can give you the complete course. So this will give you a brief background on xylazine, what it is, how to recognize it, and I highly suggest everybody takes the training DA Ryan's about to offer you. Thank you for your time.
Thank you, David. Thank you. Appreciate it. All right, one more public announcement of things that are out there. Patty McGaffrey, you want to talk a little bit about your presentation? Where is Patty?
Sure, sorry,
Oh, there you are. Okay.
I'm muting and everything. I just wanted to announce that we're having a presentation on May 30th, where DA Ryan is going to join us. It's a mom who's coming from the organization Song for Charlie. She is a mother who lost her son to the purchase and ingestion of a fake pill that was laced with fentanyl. And so we would love to have as many community members join us on May 30th at 7 p.m. at Waltham High.
Okay. And thank you, I'm glad that David was able to go to that training that we talked about last time, and we're going to have the whole team that did that training be available for the presentation. So just for planning, we will see you on Thursday, June 15th, and then again on Wednesday, July 12th. And as I mentioned before, we've got sort of a full agenda for both of those. I think great presenters. So we look forward to having you with us. Enjoy this beautiful weather. Thanks to Madeline for getting us all here. And if you have something else that you think you'd like us to present at the August or September meeting, just let Madeline know that. Thank you so much. Take care. Bye-bye.